Dear participants, Assalamu alaikum and very good day to everybody. This is Professor Dr. Fatema Ashraf, working in the Department of Obstetrics and Gynaecology at Shaheed Medical College Hospital, which is a tertiary level hospital of Dhaka, Bangladesh. So I am really honored to be here in this prestigious BIMSSCON 2020 to discuss on a very important topic today. Actually, when the whole world is has come to a standstill due to COVID pandemic, the group of enthusiastic people who actually organized this virtual congress to impart knowledge for all others and they break the boundaries. I should say that they break the boundaries and make the platform for sharing the knowledge with others. So without further ado, let me start my session. In this session, my co-facilitator is Dr. Jobaida Sultana, who will be demonstrating on the hands-on part of this PPID program. Now, I want to share my slide first. So my topic of discussion is Introduction to Postpartum Intermittent Contraceptive Device, in short which is termed as PPID, that is actually a form of long-term reversible solution for a planned family. You all know that Bangladesh ranks 8th position in the countries who are densely populated in the world, and this huge population actually impose a toll on different aspects of our agriculture, our economy, unemployment, nutrition, and so many factors. So the slow rate of progress in health and nutrition sectors are the most notable that are hindering Bangladesh's development efforts towards SDG. Now, family planning nationally and globally imposed immensely on improvement of maternal health, infant and fetal health, patient empowerment, and about the safety on the environment. While in personal or family level, family planning means a healthy family, a happy family. So it does not mean that family planning does not mean only the use of contraception. It has huge extension of the, and it's a huge impact on different aspects of life. We all know that Bangladesh has made remarkable and rapid progress in many family planning and other health indicators. And Bangladesh is actually committed to achieve the Sustainable Development Goal. In July 2012, at London Summit of Family Planning, Bangladesh expressed its commitment to achieve the overall goal of ensuring quality and equitable family planning services for all eligible couples, especially for the poor, by improving its access to and utilization of family planning services by all. So it's actually the national commitment of the country. Now, what is our present status about the family planning issue? We know that the contraceptive prevalence rate, according to the BDSS for 2014, it is 62%. And the total fertility rate is 2.2 per women in last 10 years. The unmet need for family planning is 12% among currently married women. And the important issue is that all method discontinuation rate is 30%. So people who are using contraceptives, that is the eligible couples who are using contraceptives, they might not continue that for the time being, that is how long it can be continued as a specific method. The discontinuation rate is high, around 30%. Now, what is our expectation? According to the 2020 commitment, we should reduce the total fertility rate from 2.2 to 2, and we should increase the contraceptive prevalence rate from 62% to 75%. We have to increase the long-acting and permanent methods from 8.1% to 20%. So you can see here that the use of long-term and permanent method is so poor, or the frequency is so low, and it must be increased to 20%. The government is trying to change in the method mix more towards the long-acting and reversible contraceptive and the permanent methods. Otherwise, the daily methods which are used like oral pills or condoms, that might not be continued by the couple properly, and there is a more chance of discontinuation of the methods. For this, the new strategy have been implemented, which included postpartum family planning. And for this, for the effective use or application of this postpartum family planning, which extends for 1 year following delivery, the government tried to involve the obstetrician in the family planning program. Now, you all know about FIGO, the International Federation of Gynae and Obstetrics. That FIGO, in collaboration with Obstetricians and Gynaecological Society of Bangladesh, that is OGSB, have launched a project in Bangladesh to foster family planning activities by postpartum ICT insertion from July 2015 to April 2020. So this project actually introduced the country with, or the obstetrician of this country with the PPIUD. So PPIUD is a form of actually a form of a property or intrauterine contraceptive device that is used within the endometrial cavity to impart the contraceptive purpose. But it is different from intrauterine contraceptive device, in that means that the couple who might not come to the doctors or the service center for seeking family planning methods, when they come for the purpose of delivery to a center, or they are exposed to a service provider for delivery purpose, that is a good opportunity for the obstetrician or the service provider to motivate the female or the couple for introduction of a long-term method, that is postpartum IUD. Now, how PPID will help? It will help in pregnancy spacing. It will reduce the unwanted pregnancy. That is very important. The more the frequency of unwanted pregnancy, or the more the rate of unwanted pregnancies, there is more chance of maternal morbidity and mortality, because most of the unwanted pregnancies are terminated to a unsafe termination of pregnancy. So PPID will reduce the unsafe abortion. It will reduce the maternal morbidity, and it will reduce perinatal morbidity and mortality. How? We'll see that. So pregnancy spacing, is it that it really make any difference? Yes. The importance of birth spacing, you see here that if all women waited at least 24 months to conceive again after her last pregnancy, the under 5 death would fall by 13%. So it's a huge issue that the birth spacing should be an adequate one, not only for the new pregnancy or new conception, but also for the young child who is of early age of life. The effect of waiting 36 months to conceive would avoid 25% of under 5 years. And the impact of avoiding these high-risk intervals, that is more than 36 months, would be a total of 18,36,000 deaths avoided annually in less developed countries, excluding China, where there is a one-child policy. But in all other countries, including Bangladesh, we actually lost a lot, for not only for birth space, not only for proper using of birth spacing. Now, parents who want their children to survive and thrive should wait at least 30 months after birth to conceive another child. Here you can see the same thing, that the birth interval, if it is less than 18 months, it will be associated with more small for gestational age, preterm delivery, term small from gestational age, more neonatal mortality and infant mortality. And it is at around 1.5 times more, the odds ratio is 1.5 times more than who have the proper birth spacing. Here we also see the same thing, that the percentage of children alive and not undernourished is related to the duration of preceding birth. You see that if it is less than 6 months, then the rate of children alive and not undernourished, can you compare it with the interval more and more. So here you can see that if we are not using the long-term reversible contraceptive methods like the long-term contraceptive methods, if we use the daily methods like CAP, diaphragm or condom, there is a chance of not to use the method perfectly because it is used by the couple themselves. And there is a chance of more accidental pregnancy within first year of using these methods because of their unawareness or they are not well acquainted with the method. But in case of long-term reversible contraceptive methods like injections, like intrauterine contraceptive device, implants, sterilization, there is no much change of using the perfectness of the method because it is introduced by the service provider, which is actually the expert. And here you can also see that the rate of accidental pregnancy is very minimum. So here is the importance of long-term, long-active reversible contraceptive methods. Now, women who conceive within 6 months of delivering their last baby are 7.5 times more likely to terminate the pregnancy. As we discussed earlier, the unwanted pregnancy are commonly terminated into a unsafe termination of pregnancy, and that is very important for the safety of maternal life and maternal life. Now, the birth spacing, along with birth spacing, the long-acting reversible contraceptive method or PPID also reduces the maternal mortality. The optimum use of family planning would avert 32% of maternal death. So you can easily imagine how much important is it to use a long-term contraceptive method. But the long-term other forms of long-term reversible contraceptive method, the use of PPID is far better. We'll explain that later on. Now, WHO also recommended for the proper birth interval. Now, among the other postpartum contraceptions, we can use some reversible method. We can use some permanent methods like female sterilization, male sterilization, and the reversible methods may be a long-term, long-acting reversible contraceptive methods like injections, implants, intrauterine contraceptive device, or intrauterine system, the hormone impregnated intrauterine system, and used every day are the oral combined oral contraceptive pills, progesterone only pills, vaginal rings, patches like this. So used at the time of sexual practice are male condoms, female condoms, and diaphragm. So we have to choose which one is the most perfect for the couple who is going to use this form of contraceptive method. The long-acting, about the long-acting reversible contraceptive methods, as you already know, that there are injections, intrauterine system, then intrauterine contraceptive device as copper T. So how can we compare the effectiveness of family planning method? Here you can see that this is a tier of WHO. From the less effective method means there is 30 pregnancies per 100 women in one. That is the failure rate of these methods, and towards the more effective, that is there is less than 1 pregnancy per 100 women in 1 year. So now we can see here easily the methods are comparable here, that the condoms, diaphragm are in the lower tiers of the effectiveness of family planning methods, while the reversible long-acting methods like implants, injected contraceptive devices, they are similar to the effectiveness of female sterilization or male sterilization. So you can easily choose that which one you want to introduce with the patient, whether ID implants or other methods. And only for misconception about the methods, sometimes the couple are unable to choose their more effective methods. So during counseling, we have to inform the couples about all the methods, and we have to tell the advantages and disadvantages of the methods, so the couple will be able to take their own decision, will not impose them to take this one, will not force them to take these methods. When the couple are well informed and they decide by themselves which method they will take, and if they can be able to take the right choice, only then they can continue. Otherwise, you know that there is a huge discontinuation rate, and that is very important for effectiveness of this method. So again, now we can now tell about the postpartum intrauterine contraceptive device. As we have already told that this is like that of the interval property which we use following abortion, following MR, or at any time after ending of the stoppage of the menstruation, use the intrauterine contraceptive device which we mentioned as the interval IUCD. But in case of postpartum IUCD, the same property is used, but the time of insertion is quite different. It is used for immediately following delivery, that is within 10 minutes following delivery, or postpartum up to 48 hours. If we fail to introduce this PPID within 10 minutes of delivery, we can use it. We can introduce it within 48 hours after delivery. We can use it during cesarean section. And this is why this is different from internal contraceptive device is that once the people come to us for the purpose of delivery, and if we can make them able to get this intrauterine contraceptive device immediately after delivery, then there is no need for further patient need not to appear further for this contraceptive purpose, because once the patient is discharged from the healthcare centers, they might not come again for contraceptive purpose, or they are thinking that they will come, but sometimes that can happen that before coming to the for seeking the contraceptive, they might get pregnant. That's why it is the most good opportunity to get the contraceptives before discharge. And you see that postpartum intrauterine contraceptive device is a long-term method. It can be remained effective within the uterine cavity for long 10 years or more. So the couple who have already 2 children, they can use this, and they can continue this for long 10 years. But if a couple want further pregnancy, they can remove it even after 3 or 4 years, and the removal of a property will not take much time. It will take only few minutes. And already we have discussed that why immediate after delivery is chosen, because delivery may be the only time a woman comes to the hospital. So we can cross the barrier of limited access to care, because the patient or the client is already in the center for giving birth. There is infrequent postpartum care. People may not come for postpartum care, so the service provider might not get the opportunity to introduce the family planning with the patient, and women may not come back again. So PPID is an opportunity that we can utilize the opportunity when the patients are with us. We can introduce them PPID. Now, the impact of PPID at personal level, it reduces the maternal mortality, improves maternal health, At family level, it reduces infant mortality, because we have already known that the birth spacing is very important for the safety and to reduce the morbidity and mortality of the infants under 5 death of the children, and it improves the child health. It will improve the lifestyle, both social and financial. And at national level, it will reduce the unmet need of family planning. It will empower the women and enhance the education and success story for the population control. So if we want to know more about the intrauterine contraceptive device, it is a small plastic device inserted into women's uterus to prevent pregnancy. The most commonly inserted intrauterine contraceptive devices are shaped like a T and have a copper wires or bands on the plastic stem and arm. Here is a transverse arm, and it is there is copper wires here on the transverse arm and on the stem also. So it is introduced within the endometrial cavity in such a way that the transverse the transverse limb will be fitted to the fundus of the endometrial cavity, and the stem will be within the cavity, and there is a small string, and that will remain outside the external os of the cervix, so that patient can easily feel the string, and she can make sure that yes, there is a thread, so puberty is in situ. Now, how to implement this PPID? Actually, it's a newer form of introduction of intrauterine contraceptive device. Commonly in this country, we were used to introduce the puberty at interval period, but the project which comes from 2015 by FIGO and OGSB, the PPID implementation started in this country, and it needed the demand creation through awareness. And for application, it needs proper counseling of the patient and then experts for introduction of the intrauterine device immediately after delivery. Because immediately after delivery, the size of the uterus is larger, you all know that. And even during cesarean section, if you want to introduce, you need some expertization or training for introducing PPI, for application of PPID. So for puberty again, which puberty we are using, that is 380A. So and it is effective for up to 10 years because there are other forms of puberty, and which we are using as PPID, that is 380A. The rate of perforation is similar to or even lower than interval one, because there was a false belief that as the uterus immediately after delivery is a larger one, it is soft, so there may be chance of perforation. But practically, evidence does not show any increase in the rate of perforation by PPID than the interval one, and it will not interfere with breastfeeding. That is a good advantage for using puberty instead of using combined pill or other hormones that can interfere with breastfeeding. So if we want to return, or if the couple want to return fertility, you can ensure the couple that once you want further fertility, you can remove the puberty immediately, and the return back of fertility is immediate one following the removal. Now, the advantages of interval IUD. We all know that the advantage of interval IUD, that is highly effective, failure rate is so low, non-constant supply, no constant supplies needed like other forms like the injectables. That is also a long-acting reversible contraceptive method, but you have to supply that timely, a timely interval, at 3-month interval. If a patient fails to get the injection at proper interval, then again there is chance of conception or unwanted pregnancy. So, in case of intrauterine contraceptive device, there is no such need for continuous supply. It is supplied only for once. No user action is required, and long-acting pregnancy protection, easily reversible, rapid return to fertility. So all these are the advantages of intrauterine device, and that advantages are similarly used in case of PPID. Provider needed to initiate and discontinue use if they want, may cause minor pain or discomfort during insertion and removal procedure. So if we use interval IUCD, then we have to counsel the patient that during the time of insertion and following insertion, patient might feel some source of lower abdominal pain and bleeding. But once we introduce immediately after delivery, actually patient is in that position that there was labor pain, then there was pain for expulsion of the placenta. So patient will not feel any pain or bleeding only for that copper-T. That is the advantage of providing copper-T following immediately after delivery. Now, how can insert PPID? First of all, you have to select the patient. Those patients who have developed primary postpartum hemorrhage, especially following inertia, or there is a rupture of the membrane before delivery for more than 18 years, or there is any sign of chorioitis or infection, then we will not introduce PPID. We'll have to take written consent from the patient after giving her all the information about the PPID, its advantages, disadvantages, and likely information. If following vaginal delivery, insert after completion of third stage of labor. So once there is expulsion of the placenta corded membrane, only then we will use PPID. And service provider should be surgically prepared, or the introduction must be in a antiseptic way. First of all, we have to wash the vagina with antiseptic lotion, and we will hold the anterior lip of the cervix. You know, following delivery, the cervix is widely dilated and the lips are very thin. We have to identify the anterior lip of the cervix. We have to hold it with this spondyling forceps, and we then introduce the copper-T using a Kelly's forceps, not suture. This is Kelly's forceps. Because Kelly's forceps is a special form of forceps that you see during the hands-on program. And with this Kelly's forceps, as it is a long forceps, so you can introduce with Kelly's forceps the copper-T up to the fundus of the uterus. Otherwise, with normal sponge holding forceps, that will not be possible. And this needs actually some form of training of the service provider. And then we must do some post-procedure counseling. That yes, it is in position now, and there might be some minor problems like blah blah blah, this and this. Then we have to keep the records that on that day, on this day, patient we give the patient the PPID, so that after 10 years it will lose its efficacy and that must be removed. If following cesarean section, along with the consent for cesarean section, you all know that before cesarean section, we must get written consent from the patient. But along with that written consent, you have to take another consent for introducing the PPID in the process of cesarean section. And you'll introduce the copper-T into the uterus and fix a fundalism by your hand. And in that case, don't stream the thread. The length of the thread will be as it is. Keep the end of the thread within the cervical canal, and then we'll follow up the patient. And it is better to do a follow-up ultrasonography at 6 weeks postpartum, so that once the large uterus is, there is an involution of the large uterus after delivery, it will comes down to its normal position. Then whether there is any change in position of the copper-T or not, that we can assess that by ultrasonography at 6 weeks postpartum. So here you can see that at outdoor, a service provider, she is doing counseling of the patient about the postpartum intrauterine contraceptive device. Now, sometimes there may be some side effects following introduction of this IUD that should be informed and explained, that the most effective way of managing side effects of IUD is to ensure that women have been informed about what side effects to be expected, and reassuring them the side effects are commonly non-harmful, and the treating common side effects with simple drugs when needed is possible, and will encourage women to return back whenever they have questions or concerns. Because if we don't explain properly everything, then if there is some pain, some bleeding, then the patient might think that, oh, there is property and that is doing everything bad. So first of all, I have to remove this. And many service providers who are not aware about this, they can even remove the IUD with the on request of the patient, and that should not be. All the information should be clear-cut, non-alarming, and presented in verbal and written form. So critical message about side effects of PPID is that sometimes PPID can cause heavier and longer menstrual bleeding, but usually become less over time. So initially it can happen, but not for long term. And cramping may occur in the first several days. Bleeding between menstruations may occur in the first few months. So we can assure the patients that you see, sometimes there may be some bleeding in the first few months following this, but you can also believe that following delivery, the menstrual cycle may not come in a proper way. Sometimes there is long gap, sometimes there is irregular bleeding or more frequent bleeding following delivery, MR abortion. We all believe that. So if we counsel our patient properly, only then they can continue the PPID. This is already inserted. Now, if there is pain, how do you do? If there is pain, we can use the non-steroidal analgesics, we can use the ibuprofen, and ibuprofen has also some role to reduce heavy menstrual bleeding. So with some simple drugs, we can minimize the side effects, and that should be mentioned to the patient earlier during introduction of the or prior to introduction of the PPID. So patient can perceive that yes, she might have some mental preparation that yes, I can suffer from such sorts of problem. Now, sometimes there may be partner complaints like irritation from the string during sex that should not be dismissed, and partner discomfort is a common cause of IUD discontinuation in numerous settings. So, following copper insertion after delivery, that's PPID insertion, will not stream the thread because size of the uterus is larger there. When it comes to the normal size at the end of the period, and then the thread will come out. If it come out, then we distribute. And when we want to remove, we'll mention that it will not take time. We'll just grab the string and then we can remove it. So simply removing the IUD when common non-harmful side effects occur is a poor option. So people should know that the person or the couple who is committed to take the PPID, they should know that for the simple problems, you will not remove the IUD, you will not request for removing the IUD, you should continue it, because if you remove this contraceptive, you have to replace it by other forms of or other methods of contraception. And for all methods, there are some advantages, some disadvantages. Here you can see that counseling at outdoor during antenatal care is not all, but we must mention here that we must emphasize that to give PPID is a continuum of care, because when a patient comes to the antenatal care, we will counsel them. Yes, there is a method, and following this delivery, you will not take another issue with very short interval. So you have to choose a good option which is long-term and reversible. That's how we'll counsel the patient and the party since antenatal checkup from outdoor up to her admission for delivery in the indoor prior to delivery and continuum of care. So you can see that in the operation theater, outside the operation theater, there are posts like, have you given the PPID to your patients? It is just for information or reminding the service providers. And this is within the OT also, it is noticed. So before giving or before inserting a PPID, during counseling, what does the woman need to know? The service provider should know all these things, that the effectiveness of the method and how long it lasts should be explained to the patient, how to use the method, when the method can be started, the common side effects and risks, when women should attend for follow-up, when and how the method need to be renewed or how to stop using it, when fertility returns after the method is stopped, and how much it protects against STIs. So thank you all. This is all about the PPID. And for the hands-on part of this PPID, I am handing over now to Dr. Jobaida Sultana. She is the Associate Professor of the same department, Reversible Medical College, and she will, I think she is a very wonderful teacher, a mentor, and she will now explain demonstrate how to introduce, how to install the PPID. Thank you all for your patience hearing.
Assalamu alaikum. I am Dr. Jobaida Sultana, Associate Professor, Department of Obs and Gynaecology, Suhrawardy Medical College Hospital, Dhaka, Bangladesh. Today I will demonstrate you the postpartum intrauterine device in a mama-you. Postpartum intrauterine device is a long-acting contraceptive. It is duration around 10 years. It gives immediate protection. It can be inserted within 10 minutes of vaginal delivery. It is called post-placental. It can be administered within 48 hours of vaginal delivery. It is called postpartum IUD. It can be given during cesarean section and it is called intracaesarean PPIUD. Now, before insertion, some prerequisites you have to fulfill. The prerequisites are, first I have to check the consent of the patient from reviewing her records. Then I will greet the woman. I will see whether there is any contraindications of this procedure, like chorioamnionitis, rupture of membrane more than 18 hours, if there is any unresolved postpartum hemorrhage. If there is no contraindication, then I will counsel the patient about the procedure. Then I will see my logistics. I need an intact copper tube package. I will check my instruments. This is a callus forceps. This is a long curved forceps without any catch. Then I need Suhrawardy forceps. It has a catch. The difference between these two instruments that it is long and it has no catch, and the sponge holding forceps, it has a catch. This is Sims double bladed posterior vaginal speculum, gallipot, cotton swab and 2 draping sheet. I will need an assistant and a good light source. Then the actual procedure. If I have delivered the patient, then I am already prepared. If I have not delivered the patient, I will wear the mask, cap, macintosh, wash my hand properly and wear the gloves. Then I will keep a draping sheet below the buttock of the patient. Another draping sheet I will give over her abdomen. Then gently I have to insert the Sims speculum through the introitus to see the cervix and the upper vagina by pressing the posterior vaginal wall. Then I have to wash the cervix and upper vagina twice by another swab. I have to again swab the cervix and the upper vagina. Now I will hold the anterior lip of the cervix by a swab holding forceps. Then I need an assistant. My assistant will open the closed PPIUD pack from the bottom about 1/3. At this moment I will hold the IUD by my left hand, and with the help of callus forceps I will remove the inserter, the card. I have to remove all the things except the IUD, and I have to be careful so that the callus forceps will not touch any other unstressed area. Now by the help of callus forceps I will hold the IUD by its edge, its vertical arm and the horizontal arm, in such a way that thread is not entangle the forceps. Now I will insert it into the uterus. I will gently give traction to the anterior lip of the cervix by the swab holding forceps and insert the IUD, taking caution that the IUD will not touch the vaginal wall. Then slowly move it through the cervix. When I am feeling the resistance, then I will remove the swab holding forceps from the anterior lip and then put my hand over the suprapubic region, fingers toward the umbilicus. I will give upward pressure to the uterus, so the angle is straightened and helps to insert the IUD toward the fundus. When IUD is felt at the fundus, callus forceps is felt at the fundus, then I will open the callus forceps and keeping the forceps open and remove it along the left side wall of the uterus and remove the callus forceps openly so that thread is not entangled within the forceps. Then I will remove all the instruments. Again I have to reinsert the Sims speculum and we will see whether there is any thread seen through the cervix or copper T in the cervix. If copper T or thread is seen through the cervix, then the procedure is not correct. I have to remove it again and then reinsert it again. After insertion, then the post procedure task. I will remove all the instruments, put them into 0.5% chlorine solution. I will do the hand wash and dry my hand, keep the records of insertion of PPIUD, and then I will counsel the woman that her PPIUD insertion has completed, and I will talk about the follow-up visits. We can check whether the property is kept in proper place or not by seeing in the model that now you can see the copper T is placed in the midline close to the fundus. You see the copper T is placed in the midline close to the fundus. This is our aim. It reduces the rate of expulsion. So this is all about the postpartum and post-placental insertion of copper T. Now I will demonstrate you the insertion of IUD during cesarean section, the intra-cesarean insertion of PPIUD. All the contraindications are same, except during cesarean section you may see that there may be uterine anomaly. If there is any uterine anomaly, then you have to postpone the IUD and you have to give another method for this patient. So during cesarean section, I am already surgically prepared. After delivery of the baby and the placenta, then I will insert the IUD. Here, IUD is open. From a sterile IUD is given to me from the packet. I will hold the IUD by my two fingers, index and the middle finger. I will hold the vertical limbs in such a way that threads are not entangled with my fingers. Then I will insert it through. Suppose this is the uterine incision. I will go through the uterine incision toward the fundus, holding the IUD, and by my left hand I will support the fundus over the abdomen and goes to the fundus. Then I will put the IUD there in the midline close to the fundus, and carefully I will remove my finger so that thread is not entangled in my hand, and I will keep the thread toward the lower segment. I will keep the thread toward the lower segment, not pushing it through the cervical canal. Then during closure of the uterine incision, I will be careful so that thread is not entangled during the suturing of the uterine wound. So this is the intracesarean insertion of PPID. And also after operation I will keep record of it, and in this time I will counsel the patient during second or third postnatal day regarding the insertion, and tell her about the follow-up. So that is the intracesarean insertion of PPID.